Good afternoon, everyone, and welcome to the Provincial Update webinar hosted by ISMP Canada as part of the Strengthening Medication Safety in Long-Term Care initiative. My name is Shirley Drever, and I'm the project manager for the initiative. And I have many years' experience in long-term care as a pharmacist. I'd also like to introduce Alice Watt, who will be our technical host for today. Her email is in the chat if you have any concerns regarding any technical issues during the webinar. Today's webinar is presented over the Zoom webinar platform. And I have a few reminders for you that can help you to optimize your viewing and participation. First of all, we ask you to maximize the Zoom window on your computer so that you can see the slides more clearly. Set the appropriate volume. The audience is automatically muted and the video is turned off when you join. We ask that you enter questions and comments in the Zoom chat as the webinar proceeds. We always like to start our webinars with a land acknowledgement. This land acknowledgement is for the Toronto area, as this is where the ISMP Canada head office is located. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe and the Haudenosaunee Confederacy and the Wendat. We also recognize the enduring presence of the nation's Métis and Inuit peoples. We are grateful to live, work, and play on the lands and want to contribute to the implementation of the Truth and Reconciliation Commission's 8 recommendations. If you have a land acknowledgement for your area, please feel free to share it in the chat. At this point, I'd like to hand things over to Carolyn Hoffman, our CEO, to go through the agenda.
Thank you, Shirley. Welcome everyone to the Provincial Update on the Strengthening Medication Safety in Long-Term Care initiative. You have a very special webinar in store for you. We are so pleased to talk to you a little bit about the initiative, very briefly. A little bit about Trailblazer Opportunity, brand new opportunity, phase 2 of the initiative, and we're excited to share some of the details. And if you are not a champion home, but you want to dive in and do some work with us on medication safety, you might want to be a Trailblazer home. So we're going to share some information on that today. We have 3 extraordinary presentations from the champion homes themselves. 3 of the 10 are presenting today. On the incident analysis process, Shannon DeMerchant and Jennifer Evans from Extendicare York Sudbury is here. On automated dispensing cabinet implementation or distractions project, we have Mayor Cardule from the Fairview Lodge, Whitby. And on adopting a model policy for youth in a home, we have Alex Lamson from Upper Canada Lodge in Niagara-on-the-Lake. We have a few brief faculty updates at the end. Throughout, we invite your questions, comments for any of the speakers on any topic that you might want to ask on this initiative. We would like to acknowledge the 3-year initiative is funded by the Ontario Ministry of Long-Term Care. This work includes addressing Justice Galiza's specific recommendations with respect to detecting potential medication incidents that would otherwise go unnoticed. And certainly I want to take the opportunity to say the views expressed on the webinar today are the views of ISMP Canada or the views of the champion homes, and they do not necessarily reflect those of the province. On the next slide, a very brief high-level overview. Hopefully you know all of this already, so this is a refresher to you. ISMP Canada has been funded to develop tools, resources, coaching, facilitation approaches in 4 main areas: education and model practices, quality improvement, measuring and evaluating, and medication incident analysis. In the center of all of this great work is the home, with the heart of the home being residents and families, and of course the importance of their engagement no matter what you're working on in the home. On the next slide, we'll move to share our pictures of the ISMP Canada long-term care team. I'm very privileged to be working with an amazing team: Melissa, Alice, Dr. Mike Hamilton, Ali Shahzada, Anurag Pandey, Rajiv Ramprasad, Shirley Drever, and Sylvia Highland. What a great team. They are working together, and I think it really is maybe unprecedented in the way that bringing nurses, physicians, pharmacists with high expertise in medication safety together with quality improvement consultants and other types of experts, bringing them together to work on this with the homes, to meet the homes where they are with medication safety and try and advance it, I believe is unprecedented in this approach. So amazing team. Thank you to the team, and you'll see evidence of their work throughout the presentation today. Thank you to Champion Homes. I want to pause here. The 10 Champion Homes listed alphabetically on this slide, and 3 of them are with us today. Those 10 Champion Homes almost a year ago said, yes, we want to be part of medication safety initiative, and we want to sign up to help ISMP Canada learn, develop their tools, protocols, refine them, and to get them ready for phase 2. And you've done an amazing job. You truly have helped us. We have updated, developed new tools. We've done so much work related to this collaboration with these wonderful leaders in the Champion Homes. Their intensive efforts have truly made it possible to be moving to launch of phase 2, Trailblazer Homes. In this phase, we're going to offer up to 100 homes to work closely with us, to be invited into a cohort called Trailblazer Homes that will receive tools, facilitation, and coaching that have successfully supported the great work in the Champion Homes. And so we're going to offer registration to up to 100 homes. There is a link on our website. By all means, go to our website, and registration will close when we have 100 homes registered. We want to focus with those 100 homes in a new phase about providing virtual support to larger groups of homes. And one way we're going to do that successfully is to provide a menu of options to the new Trailblazer Homes. And these menu of options are based on what we learned with the Champion Homes. And so if that sounds appealing, go to our website and register, or if you have any difficulties with that, email us at ltc@ismpcanada.ca, and you'll get directly to us and you can submit your registration. I do need to tell you that we already have a number of homes registered. So we're excited to say that homes are joining us in this Trailblazer phase, and we do invite you to come. If you're interested, please do register. What would be the next step? Well, step 2 is to submit your data to ISMP Canada on 4 core med safety indicators. All of the details are online, and showing on this slide a screenshot of the first page of an overview for you. And additional details will be given to those that register. I'll show you the menu of options shortly, and part of step 4 would be coming to the November 3rd online conference that we're going to be hosting, this great team with our Champion Homes, coming together with the Trailblazer Homes. And once you've gone to that conference, the next step would be to participate in regular online events that will be scheduled by the faculty in the various project area options. They'll help you to develop, implement, and evaluate your projects. So here's a menu of projects. Maybe your home wants to do 2. Well, that's okay. We're asking Trailblazer Homes to do at least 1 project. The menu is here. We have projects on resident and family member engagement. We have projects on reporting, learning, and acting following a medication incident in your home. And this work is based on the Canadian Incident Analysis Framework. We've got an option of working on MedRec, and certainly the leading expert, one of the leading experts in MedRec in Canada, Alice Lott, and Dr. Hamilton, for example, and many others on our team are going to be able to help with improving MedRec in your home. we still know that sadly very tragic errors occur in homes from med-rec processes that are not fully implemented. They're not complete in terms of what we know for all the steps and all the comprehensive steps to med-rec. So that might be something you're interested in. You might also be interested in one of our med management policies, model policies that we've developed. Shirley's going to talk a little bit more about these a little bit later in the initiative. And you might be looking at some med management part of your process, and you think a model policy might help you get off to a running start on it. You can take those model policies, adapt, implement, and evaluate them locally, and that would be a great project. We'd be happy to help you with it. And with all of that in mind, the other option is for you to say, ISMP Canada, our priority med management project isn't on this list, and we want to do a focused project in a certain area. Reach out. We would love to hear that, and we have the experts and the faculty to provide that kind of support to homes that are moving through the Plan, Do, Study, Act cycles. And we're going to see some of the evidence or some of the examples of projects today, and including automated dispensing cabinets. There are many different types of things that could be done, and we're open to hearing from you what's your priority and joining this cohort of Trailblazers. So November 3rd online conference, here's an early draft of what we are going to be looking at. We're going to have the opening comments. The Ministry of Long-Term Care official will be joining us. The Champion Homes, we've learned a lot. So we've got faculty, including these three and perhaps others, likely others, joining in a rolled up summary of what we learned from the homes in terms of data, etc., and outcomes. And then the homes themselves, the Champion Homes, will be invited to give rapid fire presentations of what they did and what they learned. So that'll happen up till about noon, and then the afternoon we'll be breaking the homes into smaller groups of the Trailblazer homes into the groups of interest. So if you're interested in med-rec, there'll be a room for that. If you're interested in a quality improvement initiative, but a different one, there'll be a room for that. If you're interested in resident and family engagement, Melissa will have her room there. Carolyn will be focused on incident analysis, and Shirley will focus on model policies. And I do want to bring forward Anurag and Ali. They are very high experts in process improvement, and they'll have that room, that QI room, no matter what project you're working on. And then we're going to have a break and finish off the afternoon with working more on that. It says we're ending at 2:30. We're probably ending at 3:30 to give time to really have that full day with you. And then the next slide, we will wrap up the Trailblazer opportunity and turn it over to Champion Home updates and a little bit about their projects. And I am so pleased to introduce the first group on the next slide that will be presenting. And this is Shannon and Jennifer from Extendicare York on incident analysis. Over to you, Shannon and Jen.
Hi, I'm Shannon DeMerchant. I'm the Assistant Director of Care here at Extendicare York. So we are going to just change the setting here. I can see the screen. We're going to review our incident analysis that we did for two medication incidents that we had. So our working group team members attended the incident analysis workshop for long-term care offered by ISMP. And we followed the templates for comprehensive incident analysis, which we've utilized the Canadian Incident Analysis Framework. We applied the learnings to two de-identified incidents in our home, and we are going to discuss one where the incident was a wrong resident received the wrong medication. So one of the areas of the incident analysis is to complete a timeline. So our timeline: background information. Resident A is an elderly female with a diagnosis of congestive heart failure. shortness of breath, pneumonia, and had multiple hospitalizations. She was noted to be weak, lethargic, and confused upon returning from the hospital at this time. And our information source is the chart. On day 1, she was treated for lower lobe pneumonia. That was located in her chart. Day 2, she was noted to be hypotensive, so her medication was discontinued and we increased our monitoring. That information was located in her chart. Current medications that she was on, she has a few there. I just want to highlight that she was on hydralazine. That will be important moving forward. So day 16 at 1900, resident A was administered resident B's medication in error by RPN 1. RPN 1 was a new grad and she was working alone. Generally, we have 2 RPNs on the unit. At this time, she was by herself, RPN-wise on the unit. There was an RN in home. RPN reported the error immediately to the RN that was on duty, and this information was found in her chart. And of note, the medications that she received were Aventil, Invega, Pregabalin, quetiapine, and hydralazine. So just to keep of note, the hydralazine, 25 milligrams, which she was on normally, but a different dose. And most importantly was the quetiapine. So continued at 1915, Dr. A was notified of the incident by the RN. So we received orders to administer the hydralazine as per usual and the K20 as per usual and hold all her other medications. Neuro and vital checks were ordered every 4 hours throughout the night, and her blood pressure was taken. Resident was instructed to notify the staff if she was feeling unwell. And this was noted in our information source was the chart and the EMR. Power of attorney was notified, and at the time the power of attorney did not express any concerns. At 1945, so about half an hour later, the manager on call, once all of these actions were taken, the manager on call was notified of the incident. So the next day, just after midnight at 0:35, the resident's blood pressure was noted to be low at 72/41 with a pulse of 64, respirations of 16. Her oxygen was stable, but she was noted to be weak and lethargic. And we received this information from, should be at the chart as well, but also the RN interview. Later that morning at 9:58, Dr. B, which is her primary physician, was notified of the error from the previous night. And that was in the chart. Dr. B extended the neuro checks for 24 hours longer and held all medications until the resident became more alert. And that was notified in her chart. At 11:30 that day, the daughter visited the home and spoke to the RN about the incident. The RN called Dr. B, who ordered urine sample, lab work, and normal saline boluses. He also said to send the resident to the emergency department if she continued to decline. And those things were noted in the chart and the progress notes. At 13:15, the RN discussed with the daughter palliative care and pronouncement in the home for resident A, just as a precautionary issue. And that was a progress note. At 14:44, the blood work was noted to be abnormal and the urine had increased leukocytes, and that was from the lab report. Day 17 at 14:44, that was on the previous slide. Dr. B called and stated the resident can go to the hospital or stay in the home as per the family's decision. So I left it up to the family on what they wanted to do, and that was in the chart. The doctor ordered Narcan and as the preventative, just in case anything narcotic wise may have been interacting or whatnot, and that was administered. At 16:47, RN4 noted that resident A was lethargic and no longer responding verbally. That was in the progress note. RN4 spoke with the resident's daughter, who said she wanted to wait to see if the resident would rouse more after the second bolus of saline was administered before deciding if she wanted to send her to the hospital at that time. And that was, her information source at that time was received from the RN interview. Shortly later at 17:27, the resident continued to decline and be lethargic, and the family decided that was the time to send to hospital. So she was transferred to the emergency department. That was located in the chart. At 21:28, RN forward received information from the hospital that the resident was being admitted for monitoring. Her vital signs were stable, and the hospital also administered Narcan as preventative. And the physician noted that the sedation and increase in lethargy was related to the quetiapine that was administered. And that was found in our progress notes. At 0600, RN2 received a call requesting more information from the hospital as resident A was experiencing shortness of breath and still unable to answer questions. On day 20, the hospital called to inform us that resident A would be discharged in the next 1 to 2 days as she was back to her normal self again. And then on day 20, so shortly after, the resident did return from hospital and has had no lasting effects. And that information was, our information source was the chart and the progress notes. So that was our timeline. From our timeline, we continued with the constellation diagram. So if you look in the middle of the green, the incident is the resident had another resident's medication administered, which caused significant sedation. The outcome was that she was hospitalized and she had a full recovery. Around the green is a darker blue. There's care team, organization, task, equipment, work environment, and patient. So we did go through all of them, but for purpose of this meeting, we will focus on the task. So at the top right. So task, the RPN did not follow med administration policy by checking the medication list on the EMR versus the medications themselves in their blister pack. And we asked why. She had already done the check prior to being interrupted. So she was interrupted after she did her check. Then she wanted to save time by putting that pre-pour medication that she had already checked back in her medication cart while she attended to the emergency that interrupted her. She felt pressure to attend to the emergency and did not enlist the help of the RN that was in the home or call the code blue, which would have initiated all of the registered staff in the building to come to the unit and assist. So she was unaware of available supports to her per staff and per policy for emergencies. So essentially she was interrupted. She had the medications ready she had done her check, she had it ready to go, and then she put it back in the cart. And then when she went to give the resident the medication, she did not grab the right medication and did not double check it again because she had already done the check prior. So if you look down at the bottom, can't quite see it, Shirley. I can only see half of it.
Oh, okay. All right.
So work environment, interruptions during MedPass was a huge significant factor. And then I can't see what's below that.
All righty. So, so under work environment, she had the interruptions during the med pass. And then, as you had already noted, she had that emergency that she had to deal with immediately. You already had said earlier that there's only one RPN on the unit rather than two. And that caused her to feel that she had to respond herself during the med pass. And our finding at the end of this causal chain was that we felt that the shortage of staff on that unit on that particular day led to the RPN being the person to respond, and added to the fact that she was distracted from her regular process of med admin.
Correct. Okay.
Sorry about that.
Okay.
All righty.
So then following our constellation diagram, we completed an action plan. So summary statement number 1, RPNs do not understand how to direct staff or access supports, which would have been the RN, for an emergency during the med pass. This increased the likelihood that the medication would be administered to the wrong resident, which caused a hospitalization, but without lasting effect. Our summary statement 2 is multiple interruptions from staff and family during the med pass increase the likeliness of the medication being administered to the wrong resident, causing hospitalization without lasting effect. So we did several things. This is 3 of them. So the first one is educating a family about limiting interruptions during med pass at town hall, and we measured the impact over 1 month. So this was addressed at our town hall meeting. It was specific and it was measurable. We were able to use a tick format for the nurses to calculate how many times they were interrupted and whether it was family, residents, or other issues. So that was utilized. So using the form to track that was achievable, relevant, time-bound, and under hierarchy of effectiveness is rated as low as it's a person-based change, and accountability was the DOC and administrator who facilitates the town hall. So that was just education with the family. And then education with staff to implement, education of staff and families to the implementation of nurses wearing orange vests during the med pass for a 1-month trial period. So it's specific, it was measurable. Again, we used the form to track how many interruptions prior to initiating wearing orange vests, and then how many interruptions received while we were wearing the orange vests, and to compare if there was a change. So the rank hierarchy of effectiveness was medium, as it was a systems-based change, and that was the nursing leadership and director of care. The bottom one I can't see, but I know that it is hiring blitz to fill the RN shortages under a 6-month timeline, I believe. And it was measurable. We had our HR records and achievable. The rank hierarchy was high due to being is it organizational based, Shirley?
With system-based, yeah, system-based change again, yeah.
Okay. So that was a few things of our action plan that we completed.
Excellent. Thank you so much, Shannon.
Shirley, I'll just before we move on to your follow-up slide, there was a question in the chat and some comments, and so I'll just cover that. Thank you so much, Shannon and Jen, for this excellent work. Really strong, comprehensive analysis that resulted in system changes, or is going to result in system changes. You had a couple of our faculty jumping in talking about how great that constellation diagram is. Very important to be able to see what you need to tackle. One question was around what is the nurse to resident ratio? You talked about being short. Any comments on answering that question at this time?
So at times we did struggle for staffing, like everywhere in long-term care. Typically we have 2 RPNs. Our wings are divided into units are divided into 2 separate wings. Each RPN would take a wing. In the absence of that second RPN, if we don't have the ability to do that, we have the RN who helps with the medication pass on that side. So the RN would have assisted, but she may not have been on the unit when that incident had occurred.
All right. Thank you again, Jen and Shannon. And surely we have participants that might be saying right now, this is excellent work. How can I do this myself at my home? What would we tell them?
So we do offer every month a live facilitated virtual workshop on incident analysis specific for long-term care. This is a free workshop. It is a 6-hour workshop, including some breaks during the day. Both Carolyn and I and Melissa help with the facilitation of that workshop. So we would be so pleased if you would join us on one of the dates that are listed at the top for the dates that are still available in 2022. And this will continue on till next summer. That will be offering these workshops. So you can register online by going to our website, and we would love to have you come and join us for these webinars. And we learn during every webinar, just like our workshop, just like we hope the participants do. So please join October 13th, November 10th, December 8th. You can see on the website whether there's still availability of those dates. And we're very open to accepting other dates if there is a need within the sector as well. At this point in time, I'm so pleased to introduce our next presenter. We have Mayor Cardulay from Fairview Lodge, who is going to take us through the journey from using an e-box, you know, those toolboxes that we're all so familiar with, to implementing an ADC for the use of emergency medication supply. So I'm going to hand it over to you, Mayor Carr, for the next few slides.
Thank you, Shirley. So can you go back to the previous slide, Shirley?
Yeah.
Okay, so hello everyone. My name is Mary Cardulay. I am a registered nurse and the medication and management clinical lead for Fairview Lodge. One of the quality improvement projects that we implemented is the use of the automated dispensing cabinet for the use of emergency medication supply to reduce the time taken to obtain and administer emergency medications ordered for residents. Staff training and implementation occurred in June, and the Fairview Lodge team completed the advanced process mapping workshop, and here we mapped out the old e-box process and the new ADC process to see if there's any improvement. So if you can see, this is the process map for our old e-box. So here are the steps. The RN receives the order from the prescriber and enters the order in PCC, calls the family for consent, then goes to the e-box and retrieves the medication. If the medication is a controlled substance, the RN looks for the first floor RN to obtain the controlled substance lockbox key and removes the medication from the e-box. The RN signs the medication out and the order form will be faxed by the RN on night shift to the pharmacy. The RN goes back to the unit and gives the medication to the RPN. The RPN administers the medication as per doctor's order. Meanwhile, the order is transmitted to the pharmacy. If the order is received by the pharmacy before the cutoff time of 3 p.m., the remainder of the medication will be sent in the evening. If the order is received by the pharmacy after 3 p.m., the remainder of the medications will be sent the next day at regular delivery time, as well as the replacement medication for the e-box. Now, we audited 20 orders looking at how long it takes from the time the medication order was received until the administration of the first dose using the e-box. The result of the data collection on the old way using e-box is the average time from order written to administration of the first dose to the resident is 6 hours and 3 minutes. We also mapped out the new process using the automated dispensing cabinet. And here are the steps. The RN receives the medication order from the prescriber, enters the order in PCC, and calls family for consent. The RPN confirms the order, goes to the ADC, retrieves the medication, and administers the medication as per doctor's order. Meanwhile, the pharmacy receives the order. If the order is received before 3 p.m., the remainder of the medication will be sent that evening. And if the order is received after 3 p.m., the remainder of the medications will be sent the next day at regular delivery time. Now, using the new way, there are fewer steps, less time the RPN waiting for the RN, reduced workload for the RNs, and no more reordering. But does it make a difference in the time it takes for the medication to be administered to the resident? Again, we audited 20 orders to see how long it takes from the time the order is received and until administration of the first dose using the new way. The average time from order written to administration of medication to resident is 5 hours and 59 minutes, a savings of 4 minutes on average. So this is our initial thoughts. Even though the time difference is not that significant yet, We know from the literature that the use of the ADC is a safer option than using the e-box for emergency supplies. With this change to ADC, the residents are profiled with two identifiers, their name and their date of birth. So the medication is accessed and documented for specific resident. High alert medications are stored with single product drawers to reduce the risk of incidents in product selection. The nurses no longer have to reorder to replenish the supply of the ADC as there is automatic replenishment. We can rely on the emergency medication supply being on hand when we need it. We have to consider that this is a new process. This is the first data collection since implementing the ADC, so there are still kinks to be worked out. The staff still going through change management, and there is potential to improve over time as comfort level improves. It has been a great learning experience to find out through the data collection that the biggest delay in administration of meds from the emergency supply is the nursing decision to delay administration to the next scheduled dosing time. We need to evaluate why this decision to delay therapy is happening. What is best for the resident? If they need an antibiotic from the emergency supply, does it make sense to wait until morning to give it? Now, there is a possible need for a policy on the administration of first doses of antibiotics, which account for most medications accessed from the emergency supply. For the project improvement steps, the team completed the designing test of change advanced workshop with ISMP, and here we brainstorm ideas to shorten the time to first dose administration. We looked at the impact effort matrix of these ideas and started the plan, do, act, study, and act, or PDSA, for testing changes. These ideas are to inform prescribers when writing antibiotics order to include first dose as stat. The next one is staff education on the importance of immediate administration of first dose and to develop a first dose policy. It has been a great learning experience to identify ways to improve medication safety through our journey from e-box to the automated dispensing cabinet. Thank you.
And thank you so much, Marikar.
Hi, Shirley. If you're okay, I just see a question. Can I jump in and
Sure, absolutely. Yes.
It's always good to benefit from the presentations and when there's a question. We have a question, Marikar. Did you obtain the funding for the ADC through the Medication Safety Technology Program funding from the ministry? Are you aware and are you comfortable speaking to that? Over to you.
Can you repeat the question, Carlin?
They're wondering whether the automated dispensing cabinet was funded through the MST program through the ministry.
Yes, it was funded by that MST.
It was funded through that. Great, great. That's excellent. You know, I have a question as well, Marikar. Great work here. Any tips or any reflections on how you actually were able to keep this process moving forward? You know, the data collection, you know, then implementing, then the evaluation. And any tips for us or insights into how you did this great work in your very busy home?
So we know it is important that we have to make sure that our residents is safe through medication management. And so we are, we know where it's busy right now with the pandemic and all these things going on, but we have to make sure that we are following up with the tasks that we need to do. So we put in our schedule to do these things. So for the ADC, there was a lot of kinks and struggle with this, but we know that it is the safer option. So we collaborated with our other homes and the pharmacy on how to improve the process. So and as we go on, we're going to continue to do our audits and see that and make sure that we are improving.
Thank you, Marika, and everybody at the home. Such great work. Back to you, Shirley.
Great. Thank you very much, Carolyn and Marika. It's always a pleasure having you speak at these updates. I just wanted to spend a couple of minutes now on model policies. We, over the course of the initiative, have been introducing model policies for different med management processes that happen in the home. And to date, we have done them for medication reconciliation, high alert medications, monitoring for preventable harm from medications, quarterly medication assessments, emergency medication supply, drug destruction and disposal. In the next few weeks, you'll see posted on our website a policy on medication storage and a second one on automated dispensing cabinets. So you'll see those probably before the end of this month. And so we're looking forward to gathering some feedback on the model policies that are posted on the website. If you're able to use the model policy to adapt the model policy and implement it in your home, we'd love to hear your feedback on the model policy, because we want to improve it based on some input from the sector once it's been implemented and once it's out there and being used. So please visit our website to look at the policies and see whether there's something that you could use in your home, and as well provide us some feedback if you can. The next one that we're working on right now is a policy that encompasses incident reporting and learning. So watch out for that one over the next month or so as well. And with that, I'd like to introduce our next speaker, who is Alex Lanson. Alex works for the Niagara region, and the home that he's representing is Upper Canada Lodge. I'd love to hear his adaptation of the model policies and how they went through this at their home. So this is a lovely picture of Alex on the right, and he can take it from here. Welcome, Alex.
Thanks, Shirley. Hi, everyone. It's always a pleasure to be part of the provincial webinar for ISMP Canada. So I'm one of the managers of clinical practice for the Niagara region. So we have 8 regional long-term care homes in the Niagara region, and part of my role as the project lead for the ISMP 10 champion homes is policy development and revision. So it is a very great opportunity for us to align all of our policies and procedures based on best practice standards developed by experts. So if you could go to the next slide.
I would love to.
So this is an overview of our project. So the green indicates we have completed our deliverables. So we completed the medication incident analysis from last year, and we did completed the MMSA assessment for year 1 and year 2 for the MST funding and for this project. The yellow boxes indicates they are still in progress. So we have 4 in our to-do list, so which is the resident and family engagement. Under the resident and family engagement, we revised our process for the medication safety meetings to include residents and family, and on those meetings, including medication incident analysis and action plan development. For the patient safety celebration, I think that was last week, we developed the lanyards to cue staff in different processes, which includes asking for consent and medication script when providing education. And we also have 2 quality improvement initiatives in progress based on the identified processes that we have to improve on the home, and adapting 2 model policies. So we recently implemented the monitoring for preventable harm for medication, And I think we would be doing the medication storage once it's online and available from ISMP. And if we completed all of those boxes, and hopefully they would be in green in the next few weeks or months, then we would be happily celebrating our success for this initiative. If you could go to the next slide. So currently, our monitoring for preventable harm for medications are based on the Gillis inquiry, which includes the recommendations to improve medication safety, the minister's directive, which was recently revised for glucagon and hypoglycemia, the policies and procedures for both Niagara Region and our CareRx pharmacy partner for medication incident reporting and critical incidents. So I think as an organization, we need to be able to support the clinical judgment of our nursing staff in identifying clinical situations that warrants further investigation, not only limited to hypoglycemia and glucagon usage, but also to include other possible medication incidents or adverse events in relation to new changes in residents' condition, like decreased level of consciousness, they have new onset of diarrhea, because, say, for example, there were recent usage of antibiotic and other incidences that we have to rule out if it's medication incident or adverse event. So if you could click this slide, thus we would want to develop a process and procedure for monitoring for preventable harm for medications, which includes education on what are the things that the nurse have to assess and rule out, and what are the things that they have to check on patients' charts, especially on previous progress notes in the past 7 days, or their medication administration or any new blood work in the past week. Next slide, please. So the model policy for ISMP developed the monitoring of preventable harm from medication. So as a policymaker myself, we adopt policies and procedures based on evidence-based and developed by experts, and it would undergo further review from the expert like the ISMP Canada and also of our clinical team in the Niagara region. So if you could click that. Well, it's lunchtime, so you'll be able to see a beautiful cake cartoon. So adapting the model policy is similar to adapting a recipe of your favorite cake. You review the recipe first and make revisions as you see fit. But then again, you don't spend a lot of time writing or developing a recipe. So it has already been developed, so might as well just not reinvent the wheel, but make sure we are adapting it based on our practices in the organization or in the home. Next slide, please. So this is an overview of the process for adopting the model policy. So first, we reviewed the policy from ISMP, including reference from the Institute of Health Improvement. So the purpose of this policy is to describe how monitoring the use of small groups of designated medications as well as specific clinical parameters will occur in order to identify when potential preventable drug-related harm has occurred to a resident. So this is a process this process will assist the home to identify situations where an adverse drug event may have occurred, so including adverse drug reactions related to pharmacological properties of the medication or harm from medication errors. So further investigation will be taken to determine if the identified situation was potentially preventable. So the Institute for Healthcare Improvement developed a series of medical records audit tool, which they call trigger tools, to assist healthcare organizations assess the level of harm occurring due to an event descriptors, including the use of specific medications or your rescue medications in general. So we have reviewed the current process and identified that we only track few emergency agents, especially glucagon, as directed by the ministry. And next, we made some revisions to include home and organizational specific practices, including what is realistic in terms of our pharmacy, in terms of the changes that they have to develop and support in terms of monitoring and tracking through our quarterly in-home and corporate PAC or MAC meetings. The interprofessional team reviewed the policy and have approved it. And the last process is the change process, where we will be doing educations and provide materials like prompts and trigger tools to assist registered staff in assessing possible clinical situations with a possible medication incident and adverse event. Next slide. So this policy is intended to assist our 8 regional homes to track the use of rescue agents to alert practitioners to changes in resident clinical status that may require further intervention beyond the initial rescue, support analysis of the event preceding the need for rescue medications, like consideration of possible medication incidents, supporting internal and external reporting requirements, ensure timely restocking of medications, monitor trends in use of rescue agents through our quarterly medication reviews, and also assist in corrective action plan and practice changes for our 8 regional homes. And lastly, this policy is intended to assist the homes in monitoring lab results and clinical changes that act as triggers to identify preventable harm related to medications. And that concludes my presentation. I would be happy to take questions if you have any. Thanks, Shirley.
Thank you so much, Alex. And Carolyn, did you have
I do have a question.
Yeah.
Alex, thank you so much. What a great presentation. Keep an eye on the chat because we've just invited more questions, but I love your analogy to recipes, and looking to ISMP Canada and IHI are wonderful tips. Any other tips to taking a recipe and making it your own, like making it work in a home? You've given us some really good steps there, but any kind of, really important steps you'd like to highlight?
I think in order for us to be able to adapt a specific policy to the needs of the homes, it is very helpful for you to be able to, number one, complete your baseline MMSA assessments, because that provides a lot of information on different practice gaps or system-related risks that you wanted to mitigate. And number two is working with ISMP in terms of identifying different steps that you should be taking after your baseline MMSA assessment. Initially, when we had the MMSA assessment when we did it independently, we developed our corrective action plan. But with this initiative, I think ISMP did really push us further in terms of identifying system-based errors. And I think before we develop solutions, we need to be able to really identify the root causes, which is very helpful from the series of educations and meetings we had for incident analysis, and also developing projects and quality improvements. Before really developing solutions, we need to be able to have a very good system for us to be able to understand what we need.
Wow, amazing response, Alex. So insightful. Thank you very much. Over to you, Shirley.
Great. Thanks again, Alex, and just a pleasure having you on today. And so I just wanted to take a moment to highlight one of the other workshops that we are offering. This one is a multi-incident analysis and safety culture assessment workshop. The next one is going to be offered October 1st and October 2nd. So this is a 2-day workshop. The first day, you're going to look at an approach to multi-incident analysis, which I know is quite a useful process for what we do in our homes. And this would be a really good follow-up sort of process to look at when we do discuss things at the PAC meetings. The second day is more about your safety culture assessment, and it's been very enlightening to those who have already gone to the workshop, that we can look at ways to improve medication incident reporting. But one of the things we always find is that the basis for that is having a culture, a medication safety culture that makes people feel like they can safely report. So just wanted to let you know about that one. And now I'd like to hand it over to Dr. Michael Hamilton, our medical director, to talk a little bit more about a few of the resources that we have developed.
Thanks very much, Shirley, and it's really always invigorating and a lot of fun to talk to everybody, particularly at these provincial webinars. And we do accept feedback. We really value the feedback you've given us about what sorts of things would be helpful to you. And I'll just point out 3 that we've developed in response to some of the things that you've asked us to think about. One is a tool based on deprescribing. We'll help you as a practitioner come up with scripts, come up with questions, be able to talk with residents and families. And the second one is what questions to ask when a medication error occurs. And that's for families, for residents, to give them an expectation and understanding of what sorts of things can happen behind the scenes when an accident occurs. And the third, as we've heard about just culture, which is so important, yet very sort of difficult to develop and difficult to define. So we do have some resources based on developing a just culture. And on the next slide, you will see that there are tools available to everybody. We know that a lot of members of the audience are champion homes. We hope that those who aren't champion homes will become trailblazer homes. But regardless, there is a whole suite of resources and tools available to everybody. And this includes some of the things you've heard about today, including the model policies, MedRec quality audits, workshops of all sorts, and a lot of training, e-based training, e-modules based on quality improvement. And you too can replicate what you've heard here, and you can certainly do it, and we'd love to help you, support you. Carolyn?
Thank you very much, Mike. And with that, we draw the webinar to an end. What's coming next? Well, these things are on the horizon. You'll be seeing them shortly. A concise incident analysis workbook, more advanced quality improvement workshops that will be provided to the trailblazers, additional model policies you heard about, and we are pleased to say that important new learning has come in from incident reporting from long-term care in Ontario, and another med safety signal is being developed. So watch for that. Go to our website if you want to sign up to get those signals. And Shirley, over to you to talk about the survey that everyone will get when they close out of the webinar.
Yes, thank you so much, Carolyn. And just thank you to everyone for joining us today. When you exit the webinar, you will be asked to complete a survey, and we really do take the feedback seriously. We'd love to hear if there are topics that you would like us to cover in the next provincial update as well. So for now, I wish you all the best and hope you enjoy the rest of your day. And please, please, please take a moment to fill out our survey as you exit today. Thank you so much.
Thank you, everyone.